A very good morning to all. In the last two sessions, we discussed pineocytoma and pineal parenchymal tumor of intermediate differentiation. And today, we'll be discussing pineoblastoma, which is a high-grade tumor. Outline of today's talk includes introduction, clinical features, imaging findings, and differential diagnosis of pineoblastoma, macroscopic and microscopic findings, immunoprofile, genetic profile, and prognosis. So we've already seen what could be the masses in the pineal region. So let us skip this part. So coming to pineoblastoma, it is defined as a poorly differentiated cellular malignant embryonal neoplasm arising in the pineal parenchyma, and it corresponds to CNS WHO grade 4. So pineoblastomas are rare, accounting approximately for 35% of all the pineal parenchymal tumors. The age group is first 2 decades of life, more common in children, and mean age is 18 years, with slightly more male preponderance. The clinical features include raised intracranial pressure causing headache and vomiting, and ocular symptoms and Parinaud syndrome may be present. Imaging findings. On MRI, pineoblastoma presents as a large heterogeneous irregular pineal mass, usually more than 3 centimeters in size, with poorly defined margins, foci of hemorrhage and necrosis within, and causing compression of the adjacent structures, midbrain and cerebral aqueduct, resulting in obstructive hydrocephalus. Now, whenever the size of the pineal mass is more than 3 centimeters, uh, it is better to do imaging of the complete neuraxis, because diffuse CSF seedling with spinal metastasis is seen in 25 to 38% cases of pineoblastoma. Peripheral exploded calcification is classic for pineoblastoma. On T1 and T2 weighted MRI, it appears as heterogeneous mass with solid portion appearing isointense on T1 and hypointense on T2 images. Mild peritumoral edema is usually seen. On T2 GRE images, calcification and hemorrhage are seen as areas of blooming. On post-contrast, T1 images may show moderate heterogeneous enhancement. Differential diagnosis on imaging. Pineocytomas, these are less than 3 centimeters in size, well circumscribed masses, not causing infiltration into the adjacent structures. The other possibilities could be PPTIDs and papillary tumor of the pineal region. Next is the germ cell tumors, which is germinoma. CSF analysis helps us differentiate germinomas from the pineoblastomas, and there is engulfed type of calcification. One must also remember embryonal carcinomas. Teratomas show fat component, tactile glioma or the diffuse midline gliomas. Next possibility considered should be medulloblastomas, which are located commonly in the vermis than in the pineal region, but it may be difficult to differentiate if the size is larger. We received this case of a 19-year-old young adult who presented with short duration complaints of headache, vomiting, and decreased visual acuity. Now, this is a large, well-defined lobulated oval mass in the pineal gland bulging into the posterior aspect of the third ventricle. It shows intermediate signal intensity on T1 as well as T2 weighted images with patchy hypointense areas of GRE sequence to suggest intralesional microhemorrhages. These are the microscopic findings. So this slide shows a highly cellular embryonal tumor. You can see it's a small round blue cell tumor composed of undifferentiated cells arranged in haphazard pattern. The cells have high NC ratio with hyperchromatic nuclei and scant eosinophilic cytoplasm, and the mitotic activity is increased. These are the areas of necrosis, and this is a synaptophysin positive. Summarizing microscopic findings of pineoblastoma, it is a highly cellular tumor composed of sheets of densely packed immature cells in haphazard pattern. The cells have high nucleocytoplasmic ratio, hyperchromatic nuclei, and scant cytoplasm. Mitotic activity is high, frequent necrosis is noted. Occasionally, following type of rosettes may be found: Homerite rosettes, which are found in neuroblastomas or medulloblastomas, and Flexner-Wintersteiner rosettes, which indicates retinoblastic differentiation. These are commonly found in retinoblastomas. Then other morphological findings are pineal enlarged tumor. Now this is extremely rare and is often considered as a subtype of pineoblastoma. The histological similarity to retinal enlarged tumor or the melanotic neuroectodermal tumor of infancy of maxilla. Now, it has two distinct histomorphological findings, and there may be two components. That is the neuroectodermal component, which is similar to the sheets of small round cells found in the pineoblastoma, with or without ganglion cell component, and with or without melanin pigment within the cells. And second is the ectomesenchymal component, which contains rhabdomyoblasts, or with or without cartilaginous islands. Now, this is a second case, 3-year-old child, girl child, who was brought with complaints of excessive crying and vomiting. And you can see this is a large pineal mass here. So we did intraoperative squash smears, and these are cellular smears composed of round cells with large hyperchromatic nuclei, high NC ratio, and typically scant cytoplasm. Now the neoplastic cells tend to smear away from the blood vessels. Mitotic activity and necrosis was frequent, and usually pineoblastic rosettes are difficult to find on the. This was the gross received in the lab. The tumor was soft, friable, pinkish tan. So coming to histopathology of the case 2, again this is a highly cellular tumor composed of densely packed cells having high NC ratio, large hyperchromatic nuclei, scant cytoplasm. These are the areas of necrosis, and these are some rosetoid, or you can say tubular structures here. So we did immunohistochemistry. This was again synaptophysin positive. You can see a high Ki67 proliferation index. Now these pineoblastomas, they exhibit immunopositivity for synaptophysin, neurofilament, and neuron-specific enolase. Chromogranin A, beta-butylin, and MAP2 are weakly positive. These are new and negative tumors, and the proliferation index usually ranges between 25 to 50%. So the diagnosis should be given like this: pineoblastoma, CNS WHO grade 4. So one differential diagnosis on histopathology should be considered is the diffuse midline glioma, ATRT, and the germ cell tumors. Now coming to the molecular subtypes or the genetic profile, in the WHO CNS 5th edition has mentioned these 4 types: microRNA processing altered 1, then microRNA processing altered 2, RB1 altered, which shows retinoblastic differentiation, and MYC and FOXR2 activated. Now you can see out of this, the second group, microRNA altered 2, the overall survival rate is excellent. It's almost 100%. So these 2 well. Now coming to diagnostic molecular pathology, The copy number alterations and mutually exclusive mutations targeting Dicer1, DROSHA, or DGCR8 have been described. DNA methylation profile identifies these four molecular subtypes. Now coming to prognosis, pineoblastomas have aggressive clinical behavior. The median overall survival in these patients is 1.3 to 2.5 years. Prognostic value of molecular subgrouping is high. The pineal enlarged tumor have highly aggressive clinical course, and the negative prognostic indicators are disseminated disease at the time of diagnosis, young age, and partial resection. So take home message. Pineoblastoma is a grade 4 tumor. It is a highly cellular malignant embryonal tumor of the pineal gland. Uh, Coming to imaging, on imaging, these are irregular masses more than 3 centimeters in size, causing compression or infiltration into the adjacent structures. Uh, in histology, these are high-grade malignant small round blue cell tumors with frequent mitotic activity and necrosis, and the cells are immature or primitive type. Coming to immunoprofile, these are synaptophysin positive tumors with a Ki67 proliferation index ranging between 25 to 50%. In molecular genetics, DNA methylation profile can identify the four subtypes, out of which the mRNA processing altered group 2 has good prognosis, and overall the other groups have aggressive clinical. Thank you very much.